What's going on?
He has a pituitary tumor.
Yeah.
I don't know what it is.
You don't?
No.
It's a chordoma.
What's that?
Chordoma. It's a very rare cancer called a chordoma.
It's cancer?
It's not pituitary, even though they went up to your pituitary at Vanderbilt to do the biopsies.
They told us it was made up of just blood and bone, that it wasn't cancer then.
I got the report. It's a cancer that comes probably from our fetal tissue when we're born and things are kind of forming, and it forms these slow-growing tumors. They can be slow-growing. They can also be fast-growing, but it's called a chordoma. It's extremely rare. I'll see one maybe about every 5 years. About every 5 years.
Is it life-threatening to him?
Yes, it is. It was life-threatening in 2012. Now, what we may want to do is we may want to get our pathologist to review Vanderbilt's past slides. You know your flashlights.
Oh, that's mine. Sorry. I'll figure it out here. Okay, it's off. Is this curable?
Don't know yet. It's kind of a tough situation. I'll show you your scans and kind of go over everything. Oh, come on. Your report's hidden in here. Let's see. There we are. It's not listed under this pathology, but it's here. This is your report from August 2012. I expect that's when you had your surgery. Pituitary tumor, excision, chordoma, conventional type. Chordoma. No mitotic activity identified, which means it's extremely slow growing. Very rare. Only a small piece of tissue, not a whole lot. But that's what it is.
Okay, so what's our next step?
Let me show you this hand. I think Dr. Strait has made it pretty clear you're not operable.
Right.
And you weren't operable in 2012. They just did a biopsy. And they didn't talk to you about your diagnosis.
No.
No.
They didn't recommend you come back.
Nope.
No.
They didn't recommend any follow-up scans.
Nope.
They just let you go.
Yep.
Yeah.
How'd you end up at Vanderbilt?
Because I come over here first.
Yeah,
And my insurance wouldn't pay for me to have nothing done over here,
yeah.
and it would pay for it in Vanderbilt.
Huh. Okay.
Dr. Strait said at that time, I was down at his office at that time, not to see him, but nothing,
Mhm.
and they was having all this payment plan issues with TennCare and all that.
Yeah. Who you got now?
Well, me and who I got?
Insurance.
Amerigroup.
Amerigroup. Is it a TennCare plan?
Yeah.
Yep. Okay. Your pituitary typically sits right here in this space.
Right.
These are your eyeballs.
Right.
And there's your nose. And these are the nerves. That stripe right there.
Yeah.
That's a nerve that comes out the back of your eyeball. And it comes right through here, what we call the optic foramen. That's where it goes into the brain space. And you see it right here and here,
Yeah.
and right here and here, and right here and here. It crisscrosses right here. Your right eye crosses, the nerve from your right eye crosses with the left and goes to this eyeball goes back to this part of your brain, and this eyeball crosses and goes back to this part of the brain where the computers that process vision. And because all these fibers cross in this area, it's a real sensitive place for radiation that limits what I can do safely without making you blind in both eyes.
We don't want that.
He doesn't want anything that's going to make him go blind.
Well, nobody does. But your tumor is below this area by about a little less than a pencil eraser. This is where your tumor starts, just about 1, 2, 3 MRI slices, so it's about 3 millimeters. I don't know whether you know what a millimeter is, but
Yeah.
it's pretty small.
Yeah.
So it's close, but it's not involved in the nerves. This is the tumor. It's surrounding the blood vessels that go to your brain. This is the brain stem. The brain stem is the big nerve that goes to the rest of your body. And it's also very sensitive to the radiation. If I gave you too much radiation here, it could paralyze you.
Don't want that neither.
So you couldn't walk. And it's kissing your brain stem right here. That's the tumor of the cancer. Chordoma. And it goes down just in front of your spinal cord, right at the base of your brain. It stops right about here. That's your first neck bone, going right up at the bottom of your brain. That's right where it stops.
Sorry about that.
If you could turn your phone off or mute it, I would greatly
I'm
appreciate
cutting her off right now.
it. Thank you. This is what we call a sagittal section. And it's slicing you down there, straight down the middle. This is where they did your surgery. They went up through your nose, they cleaned your sinuses out, they busted through the bone right here, and they kind of sucked some tissue right out here in your pituitary. That's where it sits, right here. And they did your biopsy right here. It's actually a little bit below your pituitary. And it's involving this muscle, this bone, that we call the clivus, at the base of your skull. And this is where it's kissing the brain stem right here. See, it's kind of projecting out this way. And this is that nerve that comes out the back of your eye, right here.
So that's why when it flared up, it messed with my vision.
Probably did. Yeah.
So now it's just now come back to where I'm seeing normal again.
Wonder what made a difference.
They got me on this steroid.
They put you on steroid. It's a tough diagnosis to make pathologically of a chordoma. So I think the first step would be to have an independent review of Vanderbilt's pathology. we can get the slides, we can have our pathologist here, Dr. Hessler, take a look at it and see what he thinks. If he disagrees with the diagnosis, I'm going to recommend that Dr. Straight get another biopsy to confirm what Vanderbilt said it was in 2012. It's been 5 years ago. You can't be operated on.
Right.
These tend to be, if they're either fast growing or slow growing. I've had patients, one patient I saw probably 18 years ago that died within about 2 years of this chordoma. You've had this for over 5 years now, so we know that that's not the case. We think it's growing, so how are we going to stop its growth? But the only option that we have to stop its growth, if you can't undergo surgery, is to treat you with radiation. These require an extremely high dose of radiation to control them. For us, cure can mean stable disease.
Right.
That means it's not going to go away. But if we arrest its growth for another 20 years to keep you from dying of it, that's a success.
Exactly.
Okay?
Yeah.
But y'all can try to do that so he don't.
Well, the typical treatment that we would provide for this is at a very specialized cancer center called a proton facility. A proton facility. And it's a type of machine where they create molecules, particles of radiation in what they call a cyclotron. These machines cost upwards of $100, $200 million. And it creates this particle of radiation that they can shoot it in and deposit the energy right into the tumor, and with the hopes of sparing your brainstem and your optic nerve. That would be the ideal treatment for a chordoma in this location, I would think.
And can that be done here?
No. The closest facility is in Knoxville. The next closest facility is in Memphis at St. Jude's. Harvard has one. MD Anderson has one.
Okay,
So there are a few around the country, but you're probably with AmeriGroup, they may let you go up to Knoxville. Okay.
all right.
There's also one down in Jacksonville, Florida, and I know the folks down there because I trained with them at the University of Florida.
How does that work? I mean,
You go in every day, they make a mask, you lie on a table, they've got this big cyclotron and these big gantries, and they shoot the radiation right into the tumor. You lay there for a bit while the radiation beam's turned on, then you get up and go about your business.
if we're able to get into Knoxville, will the Sethra help us get there?
I don't know. It's not what I do. I'm a radiation oncologist, not a social worker.
Okay.
Okay.
We're just wondering how to do this because that's so far away.
well, let's see where we're at first.
Okay. We do have a social worker here that can help you with that.
Okay.
What most folks would do is probably would stay up there. So they may have some facilities that you're able to stay at close to the proton facility. First step would be to make a referral and see whether they'd be willing to see you with your TennCare. A backup plan, if they refuse to see you up in Knoxville, I have a type of machine called a CyberKnife, where it's an automotive welding robot that has a radiation unit attached to it, that we can deliver very precise radiation to this tumor, kind of like a proton, very much on the tumor. We can paint it very conformally. But the problem with the CyberKnife is we really can only do 5 treatments. And so I give a very high dose of radiation in a short period of time, which has about 2/3 likelihood of getting your tumor under control. Okay, about 2/3 likelihood.
Ain't too bad.
Can we do that
Can I
here?
finish?
Oh.
Sorry. The problem with it is that we have to do it in 5 treatments, so it's a much higher dose of radiation done in a short period of time.
Right.
In which case, it is possibly more likely to cause damage to your brainstem or your optic nerve. And that's the risk of treating to a very, very high dose of treatment in a short period of time. So it may be a little riskier. The proton therapy, they do a little bit of radiation at a time, typically over 7 weeks. So that if there is tissue damage from the treatment, it allows those tissues some time to heal, because it's not a huge dose of radiation done in a short period. It's not like the fire hose. Okay, it's more like a little garden hose. If it were me, then, and I had the ability to get a proton therapy, is probably what I would do. But our backup plan, if we can't, would be to treat you with CyberKnife. The third option would be to use conventional radiation, which is much less likely to control this tumor. We can't get a high enough dose in because of these critical structures with normal radiation to be able to control it long term. You're a young man in otherwise good health, and I think you probably need the full court press with as high a dose of treatment as we can get into this area. So the risks are damage to your brainstem or optic nerve that could affect your walking, paralyze you if it were damaged, or blindness. The other thing about the radiation, your pituitary may get some scattered radiation, and you need to see an endocrinologist. They'll need to manage your pituitary hormones, like your growth hormone, your testosterone, things like this. Your pituitary gland is sort of a hormone switching center for the rest of your body. It tells your thyroid gland, your sex glands, everything what it's supposed to do. It's your feedback mechanism for your brain. And typically radiation suppresses those hormones, so you have to have replacement therapy for it. Okay. The other thing that radiation can do, it can affect your hearing, or the nerves going out to other parts of your face that could affect your chewing and swallowing, or numbness in your face, or weakness in your face, because they're all kind of in this location. The radiation could damage this clivus, this bone right here, could cause damage to that, which can cause some chronic pain and things like this. Now, what kind of questions do you have?
If we can't do the Knoxville thing, are you good at doing the radiation?
Am I good at doing the radiation? I
Yeah.
hope so.
I hope so too.
Because I know that it's going to be hard for us to do the Knoxville thing.
The first step is see whether they'll see you. And logistically, if I were you, I'd figure out a way to do it. But it may be an insurance issue with the Mayor Group, because it costs about $100,000 to get treatments. It's very, very expensive. Whereas CyberKnife is much less expensive.
CyberKnife, okay, CyberKnife.
Yeah,
How much of a chance, percentage is
about
it?
2/3. Most of the data that I read up on proton therapy, it's about 75%. CyberKnife is probably about 65% because we'll be limited in our dose.
I mean, damaging wise, that's,
Damaging wise, less than 5%.
that ain't
Probably
too
on the order of 1 or 2%.
bad. That ain't too bad.
So can
Unless you're
he
that person. Yeah.
can he opt for that one instead of going to Knoxville, or
Well,
does he
let's
have
see
to?
let's see what goes where. All I think is Vanderbilt dropped the ball on it. They didn't.
They
tell
lied
me-
to us completely.
Well, I can't cast stones because I wasn't there.
I know.
All I can do is come in right now and see what I see and try to use
When I
my
come out,
skills to,
When I come out of surgery, they put me in the room.
yeah.
The doctor that told me that he called it something, I don't remember what it was, sarcoma or something that I had. He come in and I said, never been so wrong in my life. He said, all that was old bone and old blood, probably from an impact back when you got head trauma, is what he told me.
Well, I mean, they may have reviewed it at a tumor board, and they may have looked at it and decided their diagnosis was different, but not what I see on paper.
Well, they never
They're
told me
calling-
nothing different,
They're
never
calling it
contacted me,
chordoma.
nothing.
And it can be extremely difficult to diagnose. When I first came to town, I've been here, well, actually I grew up here, but I guess it's been 20 years ago that my first time I'd ever been sued was by a chordoma patient. And that gentleman came in and was diagnosed with a poorly differentiated carcinoma, and we were thinking it was a lung cancer. That's what the pathologist said is most likely because he was a smoker. And we treated him, and ultimately the attorney sued everybody. I was dropped from the lawsuit because I helped the gentleman, but he died of his cancer about 2 years later, and his family was able to settle with the pathologist. It's a very difficult diagnosis. It's not very straightforward. So.
Right. But it's just odd. They tell me one thing and got it on paper is another.
So,
So he needs to get the scan from Nitro or whatever he needs to get, and then we have to go from there. That's what I'm gasping.
Let me. We do a tumor conference here, and I'll go put you on for a brain tumor conference. It's probably going to be next Friday.
does he come back next Friday?
No, we just present your case. The neurosurgeons are there, and with the pathologist, and we discuss things and talk about best treatment options. In the meantime, I can go ahead and make a referral up to Knoxville, and you can go up and talk with them, and they'll talk to you. They're a for-profit facility, so they will let you know if Amerigroup's not going to work.
Does this type of cancer spread anywhere else?
I've seen it where it's spread along the spinal column, but his is talking to us. It's a slow-growing tumor. The fact that it's been 5 years since it was diagnosed and you're still with us tells us it's very, very slow-growing. So I think the likelihood of that's very low.
Good. Like that.
I just know our issue is going to be hard to do the night.
Figure it out.
And people will survive from this, right?
That's our goal. I want to try to get it under control so it never causes you a problem.
I don't know why all these phones keep ringing. I'm sorry.